we are very happy to be here and talk about our experience to introduce GAMT deficiency in the uniform screening panel for newborn screening. We don't have any disclosure related to this presentation. Next. Today we are going to talk about a little bit, I'm going to give you an overview of the creatine system. Specifically, we're going to talk about GAMT deficiency, the metabolic pathway, diagnosis and treatment. Then Heidi Wallis is going to give you a family perspective, and then we will both talk about newborn screening for GAMT deficiency, how this started and where we are now. Next. So let's talk about creatine. Creatine is a nitrogen-containing compound which is used to supply energy to muscle and nervous cells. It was identified in 1832 as a part of the skeletal muscle. The name creatine derives from a Greek word, kreas, which means flesh. Next. So creatine serves as a shuttle between the sites in the mitochondria where ATP is produced, as you can see here, and the cytosol where ATP is utilized. So creatine is converted to phosphocreatine, and then phosphocreatine releases the phosphate to form ATP in the cytosol. Hi. Sorry, I was muted. Creatine is synthesized endogenously, but also it's introduced from the diet. The major sources of creatine from the diet are fish, meat, and dairy products. The endogenous synthesis occurs in kidney, liver, and pancreas, and starts from arginine and glycine. And the first step is catalyzed by the enzyme AGAT, arginine-glycine aminotransferase, and converts arginine and glycine into guanidinoacetate and ornithine. The second step is catalyzed by the enzyme GAMT, guanidinoacetate methyltransferase. In this reaction, we have the transfer of a methyl group from S-adenosine methionine to guanidinoacetate to form creatine. Then creatine in the blood needs to reach the brain and the muscle where it can work to supply energy, and this is accomplished through a creatine transporter. Creatine transporter, which is depicted here, which is responsible for the uptake of creatine. Then creatine is converted with a non-enzymatic process to creatinine, and it's excreted in the urine. Next. What are cerebral creatine deficiency syndromes? These are conditions that are caused by defects either in creatine synthesis, therefore defect in the enzyme AGAT or GAMT, or they are caused by deficiency in the transport of creatine, therefore creatine transporter deficiency. Their clinical features are overlapping. Most of them are overlapping. They are all characterized by intellectual disability, autistic-like behavior, seizure, speech, and cognitive delays. They may present with a milder phenotype with moderate intellectual disability, attention deficit disorder, and hyperactivity. Initially, these disorders were diagnosed through brain magnetic resonance spectroscopy because of the lack of the creatine peak. Next. So this table summarizes the main clinical feature of cerebral creatine deficiency syndrome. And as you can see that all of them present very similar characteristics. Next. As I mentioned earlier, initially they were identified through MR spectroscopy, and because of the lack of the creatine peak. On the right side, you can see the brain MR spectroscopy of an unaffected patient, unaffected by cerebral creatine deficiency. And you can see that there are three major peaks: N-acetyl aspartate, choline, and creatine. A patient with creatine deficiency syndrome, with a creatine deficiency syndrome, will show the same peak of N-acetyl aspartate and choline, but is going to miss the creatine peak, and this is shown on the left. Next. There are also biochemical tests to diagnose cerebral creatine deficiency syndrome, and they are basically measuring creatine and guanidinoacetate in plasma and urine. We need to be very careful in using this test. So if you want to identify, if you are trying to identify a patient with cerebral creatine deficiency syndrome, you need to use both plasma and urine and measure creatine and guanidinoacetate in both specimen type. AGAT and GAMT deficiency are identified better with plasma. In both cases, you're going to see a very low creatine. In AGAT deficiency, guanidinoacetate is extremely low. In our experience, is undetectable. And GAMT deficiency, guanidinoacetate is very high. For creatine transporter deficiency, the specimen type, the best specimen type would be urine, because creatine and guanidinoacetate in plasma will be normal. In urine, the ratio creatine-creatinine will be high, because if you have a creatine transporter deficiency, creatine is not going to be reabsorbed, so it's going to be much higher. The excretion of creatine in the urine is going to be much higher than normal. The diagnosis is confirmed usually by DNA testing. Enzyme or transporter assays are not readily available on a clinical basis. Next. So, but now let's talk a little bit more about GAMT deficiency, which is the topic of today's presentation. As I said, GAMT, the enzyme GAMT, guanidinoacetate methyltransferase, is the second, catalyzes the second step of the synthesis of creatine. So we have arginine and glycine that are converted into guanidinoacetate through the enzyme AGAT, and then guanidinoacetate into creatine with GAMT. So if we have a metabolic block here, because the enzyme is not working properly, we are going to see an increase in guanidinoacetate, which is the substrate of this reaction, and a decrease in creatine. Of course, having a low creatine, even if the creatine transporter works, there is not enough creatine to be taken up by the transporter. So you're going to have low creatine, deficiency of creatine in the brain and in the muscle. Next. So GAMT deficiency is an autosomal recessive disorder. The gene GAMT is localized on the short arm of chromosome 19. And the incidence is estimated using frequency from genomic databases, estimated in 1 in 275,000. And given the latest newborn screen result, this is probably, this is also the number that is probably correct. The presentation, as I said, is with developmental delays, hypotonia, seizures, autistic-like behavior, and abnormal movements. The diagnosis is done by measuring guanidino acetate and creatine in plasma, and showing the characteristic pattern of low creatine and elevated guanidino acetate, and lack of creatine peak in a mass spectroscopy. So there is a therapy for GAMT deficiency. The therapy which leads to a very good outcome if initiated before any irreversible consequences already occurred. The therapy consists in administration of creatine, and also one of the goals of the therapy is to reduce the concentration of guanidino acetate, which is neurotoxic. The guanidino acetate levels can be reduced by ornithine supplementation and benzoate supplementation. Next. So the reason for using ornithine and benzoate to reduce guanidino acetate is because with ornithine we are shifting the equilibrium of this reaction backward, and also with benzoate, benzoate conjugates with glycine to form a puric acid, which is excreted in the urine, reducing therefore the synthesis of guanidino acetate. Next, the treatment is effective. Again, how do we measure the effectiveness of the treatment? Well, we are looking at the outcome, of course, the patient outcome. We look at the guanidino acetate in the patient, which goes down with the treatment. And also we look at MR spectroscopy. So here on the left, before treatment, you can see that there is, again, N-acetyl aspartate, choline, no peak of creatine, and you can see a peak of guanidino acetate. Next. On the right, this is the same patient after treatment. And now you can see that creatine appears and guanidino acetate is also reduced. Next. Okay. So I hope I gave you just an introduction to GAMT deficiency. And now I'm going to pass the mic to Heidi Wallis for who's gonna tell you her family perspective.
Thank you, Dr. Pasquale. My name is Heidi Wallace, and I'm gonna start by telling you the story of a happy, healthy young girl that was meeting her milestones. In 2003, we had our daughter Samantha, and she had a normal delivery. She met many milestones on time initially. She was smiling and interacting with us, and we thought we won the lottery, and she was our first child, so we didn't have any other children to compare to, but she overall was very happy and very social and seemed like a typical baby. Next slide, please. So by about 18 months, we started to notice that she was behind in things. She didn't walk until she was 18 months, and her pediatrician said, well, that's great. That's just in time. If it were any later, we would need to go to physical therapy. But around the same time, her grandmother one day was trying to play patty cake with her, and she wasn't responding. She was just looking away, and I with no other children that I had raised, I thought, you're being silly. Like she's not old enough to do this. She can't, but it was right at that moment that I started feeling nervous and realizing this expert grandma, she knows children, and and she looked a little concerned, and Samantha, she wasn't talking by the time she was 2, just little utterances, and she just kind of got quieter and quieter. And we did get a referral for early intervention, and we went there, and I felt out of place. I felt like, again, Sam was just kind of in this middle ground where she didn't obviously have problems. She just seemed a little slow. And I did have a lot of parents say, oh, you're worrying first mom, just, just wait, Einstein didn't talk till he was 4, and then it was 5, and then it was 6, and so we kind of held our breath. But by the age of 3, she was referred to a full workup, a full testing. And at the end of that testing, they said, by one point, your daughter is on the autism spectrum. And we again felt like she's just right here in the middle. She's not fully autistic. We said, well, if she had scored 1 point lower, what would you say? And they said, well, we would say she's normal. And we thought, well, she's shy, and she doesn't know you, and she's better at home. And we just, but clearly she was behind, but we couldn't figure out why. And she just did not fit any category perfectly. And so we pursued many therapies, speech and occupational. We did a home therapy that we had an outside group work with us and advise us on how to help her. And we were doing activities with her from the moment she woke up until she fell asleep, from pet cards to get her communicating with us, to flashcards to recognize things and just to point at them. And we made a lot of progress, and but it was definitely slow going. So next slide, please. So when she was 5, she did potty train with her sister, but obviously that's very, very delayed. And at about that time, she began having little spells where she would look up, like in the picture in the top left corner. And we talked to the developmental group that was working with us and said, she's doing this, it seems a little odd. And they said, well, she's not verbal, so this is how she stops and thinks. She's very, very based in images, and she's processing. And so that went on for about 6 months, and it picked up in frequency. And one day she was in the kitchen, and she climbed up on a stool to get a cup out of the cabinet, and she fell. And we knew, no, this is not her thinking, something is going on. So I got a video of her having one of these moments and sent it to her pediatrician. And he said, let's get you to neurology right away. And it was 3 days, and we were up in neurology. Neurology said, let's get an EEG. Yes, these are absent seizures. And while we're at it, let's make sure there's not a tumor or something causing all of this, and let's do an MRI. So unbeknownst to me, the neurologist had attended a training where he heard that, severe speech delay and different symptoms Sam had matched well with the need for spectroscopy. And so he decided to order that at the last minute. And so afterwards, we got the news that her creatine levels in the spectroscopy were very low. And then later went to genetics and Dr. Longo and confirmed that she had GAMT deficiency. So next slide, please. So we started treatment. And the treatment is, like Dr. Pasquale mentioned, creatine and ornithine and sodium benzoate. We have a little drug lab in our house where we have powders, and we have a scale, and we're mixing and measuring, and we use syringes, and this is how we administer the creatine. And it was very difficult at first, a child with developmental issues and introducing something that doesn't taste good. It was difficult, but next slide, please. She did have improvements right away. So she was diagnosed at 5.5, And the same day we got our news of the diagnosis, we got the news that she was admitted to a charter school. And we, said, okay, well, we know what's wrong with her body. It doesn't have the creatine it needs. We're going to fix it. And let's do it. Let's send her to school. So we sent her off to a mainstream kindergarten to get as much socializing as she could. And over the course of the first 9 months of treatment, she went from utterances like ma and ba or mom and ball, and we were the only people that could guess what she was saying, to now she was saying 3 to 5 word sentences and her classmates could understand her. So we saw a really great improvement, and her seizures were somewhat controlled initially, and she was doing pretty great. Next slide, please. So she was in the mainstream school through the 3rd grade, and in the 3rd grade, the content of school just becomes really abstract, and it's not, matching in letters, and it got more difficult. And Sam's learning got to about a 1st, 2nd grade level in reading and math, and it stayed there. It has not gone beyond that. Sam is 18 years old now, and she's a senior in high school. But at the time when she was, struggling in the 3rd grade, I still was this stubborn, determined mom who said, well, they're not doing it right. I've done this. I worked so hard with her when she was young, and well, let's do homeschool and, give her the one-on-one intensive therapy she needs to catch up and make up for that lost time. And so she spent the next 2 years homeschooling with me, and it was a really challenging time, I think, for both of us. She learned, but I think, it's a hard lesson to learn to accept what your influence is on your child and how much you can help them reach their full potential, and that their potential might be limited, and to just embrace that and love them. And so she was struggling, and we decided to send her back to mainstream. Well, not mainstream. We sent her back to the public school, but got her into special education, and she's been there ever since. Next slide, please. So Sam today, she is 18. Her seizures changed right around the time of puberty to be full drop seizures. And now as she's grown to be a woman, she falls and gets hurt. So just 2 weeks ago, she fell and she broke her collarbone. And for some reason, we cannot get a hold of her seizures. And we've had the picture on the right is she had a VNS implanted that hasn't seemed to work. It's just been a struggle giving her the best care and giving her a safe and happy life. Next slide, please. So if there is one thing that I want to make sure everyone on the call understands today, is that waiting for a diagnosis for a child with GAMT from a clinician who sees the symptoms, it's too late. And in my community of other parents, we all recognize that none of us who had to wait, who didn't get a newborn screen or test, have children with no symptoms. It depends on how old they are when they're diagnosed, but the consequences of a late diagnosis live on with the child and the family and the community. So newborn screening for GAMT is very important. Next slide, please. So we knew our family history. We'd actually had two children after Samantha, and they both were lucky and did not inherit two mutated copies of the GAMT gene. So they were healthy and typical. And we really wanted to have a 4th child. And we're told that even if your child has GAMT, if you can treat them from birth, they should be fine. And so we had a 4th child, and I was sure that I had my 1 in 4 and he would not have GAMT, but he did. And this is Louis. He is now 9. Next slide, please. He started treatment right away, and he took these little bottles with the creatine, ornithine, sodium benzoate, and water. And he quickly learned that you got to take this if you want the good stuff. And it took him, it just did take a week or maybe 2 weeks, of him kind of pushing his tongue out and struggling. And then he just adjusted. And he told me the other day, Mom, don't tell anybody this, but actually creatine just tastes like nothing. So he's funny, and he'll grimace and he'll complain a little, and he's a little embarrassed at school because he takes his creatine with him and has to go take it privately because he doesn't want his friends to see. But it's not been bad. It's been very easy with him. And next slide, please. He's grown just fine, and he's a typical kid and is in no special education classes, has had no therapies, and he's doing great. So I would say so far, GAMT has not affected him at all. So using our experience with treatment and other parents that we know and the costs we know, we've got an estimate here that I'm happy to share with anyone that's interested. We use the CDC's growth chart and then the recommendations for treatment based on the child's weight, and figured that per month, a 2-year-old needs $31.50 to get their supplements. And that number does go up as the child gets older, but really these are very, very, very low costs in the grand scheme of rare disease treatments. They're very accessible. We purchase ours through a supplement group in California, and it's pretty straightforward. The second part of this is just your routine visits of going in and seeing Dr. Longo or whoever your specialist is. And that's totaled for the first 18 years of life at $9,000. And of course, that's all assuming you don't get any coverage from your insurance, which usually families do. So next slide, please. So yes, Louis today, he's super creative. He's awesome. Like I have nothing negative to report except that he's a crazy boy. Next slide, please. So fortunately, I have this perspective and can tell you the difference between an early diagnosis and a late diagnosis. And I have the poster children, I have the experiences, and there's really just a night and day difference. And Louis is now 10, and he helps his sister with lots of things. He looks out for her, and he said the other day, Mom, when I hear that noise, I think it's Sam having a seizure, and it scares me. And he jumps and he runs, and he's with us. We're all looking out for Sam, and we're just really, really grateful that Samantha was diagnosed and has as good of an outcome as she does have, and especially grateful that Louis was diagnosed at birth. Next slide, please. So in 2015, the Association for Creatine Deficiencies came to town in Salt Lake City. And I knew one of the moms who had founded the group because our genetic counselor had introduced us. And if that genetic counselor had not done that, I don't think I would be a part of any of this. I'm not a big Facebooker. I wouldn't have reached out and found someone on my own. I think I would be going it alone right now. But I went by and saw them, and I was really impressed with their mission of educating and increasing diagnosis of creatine deficiencies. And so I joined the board at that time. Next slide, please. So as it was mentioned earlier, I did work for several years for the Utah Newborn Screening Program in the informatics department. And then just this year, I have made the move to be full-time for Association for Creatine Deficiencies. And we are focused on finding a treatment for creatine transporter deficiency and securing newborn screening for all babies so that they can be treated as early as possible and have the best outcomes. Next slide, please. We do this through supporting researchers. So we hold a yearly a yearly symposium where we bring researchers together. The map that you see are papers that were published on creatine deficiencies. We reach out to these researchers that we find through PubMed and invite them to speak at our conferences. We connect them with one another so that they can exchange ideas and increase the speed of their research. And we share information with them. We have a patient registry so that we are able to accurately represent the patient voice with researchers. We have a gene therapy consortium that brings together several different groups that are looking into gene therapy. And we have a scientific medical advisory board. We bring research suggestions to these researchers. We funded 4 different fellowships for 2022. And we keep fundraising to support more research. So we do all we can to help everyone move forward in research. Next slide, please. We also support families by having an online support group. We send them a welcome package with information to help communicate with their teachers and their friends and neighbors about what this new diagnosis is they have. We have a newsletter that goes out to keep them up to date. We connect them with the pharmaceutical companies that want to give updates and are recruiting for clinical trials. We educate them on the clinical trial process. And we have a global ambassador program to connect different people and find ways to be able to advocate in countries around the world. Next slide, please. We also support physicians by giving them materials to give to their families, by having brochures available, blogs available. Not all families want to join a support group and they prefer to remain quiet and on their own, but we have all these materials that the physicians can then give to the families. And we have materials for them as well to help find other physicians if this is their first patient, and to find labs that can do the appropriate testing. Next slide, please. Now I'm going to turn the time over to Dr. Pasquale. Thank you.
Thank you, Heidi. So, and now we get to the story of the newborn screening for GAMT deficiency. And this has been a story that has been possible because of the partnership of everybody involved. So again, you have seen, it starts with the family. Then you need to have a clinic and a physician who are really committed and say, we need to find something, we need to bring this condition can be screened, and we need to make sure, we need to make it happen. And then a laboratory, which happens to be my lab, who that is again willing to take up the challenge. And the state, the Department of Health, we are lucky in our state that where we have truly a good collaboration and a good partnership, and the Department of Health has been behind this from the very beginning. And then, of course, a parent organization who, the parents and the family who are constantly inspiring us to do our best to give these children the best chance that they have to a good life. Next. So the goal, when we started working on newborn screening for GAMT deficiency, the idea was we needed to integrate the analysis of guanidino acetate and creatine in our routine newborn screening method. This is possible, so we can measure these two analytes at the same time as we measure amino acid, L-carnitine, succinylacetone. This will allow to screen for GAMT deficiency without the need for additional sample. We know that there are several blood spots collected by newborns, but we wanted to preserve. We cannot keep increasing the number of blood spots, especially these are little ones. So we wanted to do that so that there was no need for additional sample, and also from the financial point of view, this would have resulted in minimum additional cost. just the cost of the reagents. No instrument, no additional personnel, everything is done at the same time. The primary marker for GAMT deficiency was obviously guanidino acetate. And then because the creatine is low, or because with the block, when you have a block in GAMT, creatine, which is the product of the reaction, is low, we used as a secondary marker the ratio guanidino acetate to creatine. Next. And this slide shows how the specificity of the screening can increase when you're using both guanidino acetate and the ratio guanidino acetate creatine. In this slide, the red dots, the red circle represent patients with blood spot from patient with GAMT deficiency, and the black circle are control. So as you can see in the top right quadrant of this graph, these are the one that would be that would screen positive using both an elevated guanidino acetate and ratio guanidino acetate and creatine. When we started the screening, we also developed a second-tier test, which allowed us to further increase the specificity. And really, in our original pilot, there were no false positive. Next. So we implemented, we in Utah implemented the statewide newborn screening for GAMT deficiency on June 1st, 2015. And we used a derivatized method, and we had implemented also second-tier test, a biochemical second-tier test for all the samples screening positive on the routine screening. In 2019, 4 years later, roughly, the Utah Department of Health took over newborn screening, and they continued the screening for GAMT deficiency, but now they used an underivatized method. New York State started screening for GAMT deficiency in the fall of 2018. They used the derivatized method and the second-tier test. After optimization of the method, they discontinued the second-tier test. The reason I am telling you these details is to emphasize the fact that, as you will see from the next slide, no matter how you do the screening, whether you use a derivatized method or a non-derivatized method, whether you use a second-tier test, a biochemical second-tier test or not, the screening works, the screening is effective, and there are very few false positive as well. Next. This is the summary of the newborn screening for GAMT deficiency from a paper that we have published last year. And we have identified a patient with GAMT deficiency after screening roughly 260,000 baby, 270,000 baby. And New York has identified pretty much at the same time a baby with GAMT deficiency. Both children have been treated since birth, and as far as I know, they are doing very well. Again, the false positive rate in Utah has been in total 0.0007%, which is very, very low. There are, again, there is a discussion on, how the newborn screening, how much adding an additional condition to a newborn screening panel, how much this will cost. Next. And I'm going to ask Heidi, who worked with the Department of Health to finalize to give you the estimate that they have worked on.
Thank you. So we estimated our cost for implementing and ongoing screening of GAMT deficiency based on Utah's situation. So this is a lab developed test. It's, we realize that's not the situation in every state, but we did think it was informative just to see Utah's experience and what that possibility is like. We did not have to add additional staff or instruments because it is multiplexed with the existing immunoassay carnitine screening. There is not an additional specimen that needs to be collected as well for that reason. The internal standards are very, very affordable. $50 for 5 years to supply of both. And we included the validation time and the staff cost of that validation time, as well as the implementation in the LIMS system. And again, we have a LIMS system that we had control over and can implement changes in. And that's, not always the case as well. And then we also added in the time for just the additional review of the data weekly and contacting 5 families a year about a borderline result, and then sequencing 3 patients a year. And these are all very padded. We didn't sequence that many families in a year, but this is, kind of the highest possible rate, just so that we were very generous in our estimate. And as you can see, we get down to a total cost of $76,000 for years 1 through 5, with 250,000 infants screened. So that's 31 cents an infant, or $76,900 to identify that one infant. Now, of course, all these numbers change based on if you're screening 500,000 infants, it would be lower than 31, or higher if it were less. Anyways, so, and then beyond that, when you do not have to factor in the implementation, the cost is as low as 19 cents a baby. So we just wanted to share all of that to kind of give you an idea of the low impact of integrating GAMT into the screening. So next slide, please. And then I'll let Dr. Pasquale finish up.
So Dr. Singh mentioned what is needed to include a new metabolic disorder to the recommended uniform screening panel. So this, I just want to go through the steps. So the first thing is the nomination of the condition to the advisory committee on heritable disorder in newborns and children. And this is done through a multidisciplinary team, so that include researcher, clinician, advocacy, and professional organizations and consumers. And this is because you need to provide all the evidences and that are necessary to the committee to make a decision, to evaluate whether this condition is really meeting all the criteria for to be included. And again, that's where having a partnership with all the players involved is very, very important. Then there is a work group, a nomination and prioritization work group that reviews the package, the nomination package, and compiles a summary with all the information that they have.
Go over that, Rob. What? You don't need.
And then finally, the committee decides if there is sufficient evidence available, and then votes to assign or not the condition to the external condition review group. The first time we nominated GAMT deficiency, we didn't have a prospective identification of an infant with GAMT deficiency, and that's why GAMT deficiency did not proceed to the next phase. Next. So once the external condition review work group completes a systematic evidence-based review, then they present the final report to the committee, which then deliberates on whether or not this new condition needs to be included on the RASP. And then finally, the Secretary of Health and Human Services makes the final decision on whether or not to add this condition to the RASP. So we are at this point now. The external condition review work group is evaluating, is reviewing all the evidences and in order to present the final report to the committee. Next. So in the summary, I think, I hope we have shown you that defects in creatine metabolism and transport result in intellectual disability, hypotonia, developmental delays. We have talked about AGAT and GAMT deficiency, which impair creatine synthesis, and creatine transporter deficiency impairs the creatine entry into the brain. Diagnosis of these conditions require measurement of plasma and urine creatine and guanidine acetate. Therapy for GAMT deficiency is geared to restoring creatine and decreasing guanidine acetate. And this is accomplished by creatine, benzoate, and glycine supplementation. And newborn screening for GAMT deficiency is feasible and can be included in all programs with a minimal additional cost and a very low false positive rate. Next. And more importantly, I hope that we have shown you that a partnership leads to success. Next. I would like to acknowledge everybody who has contributed and continue to contribute to improving the diagnosis of and the treatment of cerebral creatine deficiency, starting from my laboratory at ALP, the Utah Department of Health, both the laboratory, the Neuroscreen Lab, and the follow-up program, the University of Utah Division of Medical Genetics, and last but not least, the Association for Creatine Deficiency, patients and families that, again, as I said earlier, are the true inspiration for everything that we do. The bottom of the slide, there are our contact information if anybody wants to reach out to us. Thank you for your attention.